Okay, so I'm gonna try and keep this as organized as possible, but we have a whole lot of information to go through. I mean, essentially, well, literally, it is the whole semester. So I might not make it through everything in the time that we have, but I'll make it through as much as I can. And the way that I'm doing this is I have the actual exam. So like I have the exam printed out, but the questions aren't necessarily in order by chapter. So like I'm kind of going through it and looking at all the questions from like the blood, and I'll just kind of go through a bunch of concepts that at least cover all of these questions. And then, I'll go back to the start of the exam again and go through all the hard questions and at least cover everything so that if you know everything we talk about today, you should be able to do well on the exam, right? Well, at least whatever we get through. And I'm starting at the beginning of the semester, starting with blood and just going through the chapters as we went, because I figure that's the stuff that was a long time ago, and that might be the hardest to remember. Okay, so first off, with blood, remember the different types of cells that are in the blood, right? The blood, remember, was split up into plasma, which is like the water and stuff, and then the blood cells. So there were three major types of blood cells. We have red blood cells, white blood cells, and then platelets. So you guys should know the technical name for each of these, and you guys should be able to tell me, like, in general what they do. So red blood cells, do you guys remember what the technical term for that was? Erythrocyte. Good. So red blood cells are erythrocytes. And remember what they do, they carry the respiratory gases through the bloodstream, right? So erythrocytes carry oxygen and CO2 in the blood. And you guys who are going to be watching this video, I realize you can't really see what I'm writing on the board, so you'll just have to hear me. I'm saying everything I write down, so that'll have to work. All right, so red blood cells are erythrocytes. They carry the respiratory gases through the bloodstream. White blood cells are leukocytes. And remember, the white blood cells defend the body against pathogens. So like preventing infection, that kind of thing. And then platelets are thrombocytes. And those are responsible, or those take part in the blood clotting process. So remember we talked about different diseases based on whether or not each of these is high or low, right? Like anemia, polycythemia. You guys should know each of those terms. So like that's 6 different terms. And then we'll talk about a blood test that you should know as well. So first off, red blood cells. If red blood cells or erythrocytes are too low, right? If we don't have enough red blood cells, we call that anemia. And if the red blood cells are too high, we call that polycythemia. You could also call that erythrocytosis. Right? So, too many red blood cells, erythrocytosis or polycythemia. Not enough red blood cells, anemia. And then for white blood cells, if white blood cells are too low, we call that leukopenia. Remember, penia means poverty, right? So like when somebody's living in poverty, they don't have enough. So poverty of leukocytes, not enough leukocytes. When white blood cells are too high, that's leukocytosis. So you kind of see the same, right? Erythrocytosis, leukocytosis, like the same types of suffixes. And then finally with platelets. When platelets are too low, remember they're called thrombocytes. So that's thrombocytopenia. Thrombocytopenia, a poverty of thrombocytes. And then when thrombocytes are too high, thrombocytosis. In terms of the different blood cells, we did talk about a couple different types of blood tests that we do to look at these levels. I just tweaked something. I'm feeling so much better, but I just tweaked something. We talked about a hematocrit, and then we also talked about a differential. So you should know what each of those is. So hematocrit is the blood test that shows the percentage of blood that comes from formed elements. So percentage of blood that is formed elements, which remember are just the cells, right? So technically, this is telling you the percentage of all of your blood, that's cells, right? So all of these cells. But really, this is only telling you about one type of cell. Do you guys remember what that is? Like, if I wanted to find out if I have too many platelets, a hematocrit wouldn't tell me that.
I guess I'm thinking about the leukocytes with basophils.
That's a different type of blood test. That's the next type of blood test we're going to talk about. This is only really telling you about your red blood cells, right? So like hematocrit, we would do if we wanted to find out. So if I wanted to find out if a patient has anemia or erythrocytosis, I would do a hematocrit. So technically, it's telling us the percentage of blood that comes from the cells. But remember, 99.9% of the cells are red blood cells. So really, this hematocrit is giving us information about the red blood cells. Okay, so if I want to know if a patient has anemia, I'm going to use the hematocrit to tell me that. Okay. The other blood test is a differential, and that's the one that you were talking about with the different types of white blood cells. What the differential does is it'll take 100 white blood cells from your blood and figure out how many of each kind there are. So essentially that's telling you what percentage of your white blood cells are neutrophils, what percentage are basophils, what percentage are monocytes. So the differential is the test that shows the percent of each type of white blood cell? We'll talk a little bit more about the types of white blood cells in just a second. Okay, I think that two more questions. Okay. Before I erase this, we did also talk about, we talked a bit about the production of red blood cells and the production of white blood cells and platelets. So remember that production of red blood cells is called erythrocytosis. Oh God, no, that's too high, sorry. There's so many. Sorry, that's erythrocytosis is when we have too many erythrocytes. Okay, so production of red. Sorry guys, I'm trying to like keep this. All right, actually I'm gonna erase this. Let's go a different route. I'll erase this and then I'll do production. Okay, so production of red blood cells is erythropoiesis. Erythro, right, for red. Okay, so erythropoiesis is the production of red blood cells. Where does this happen? Where do we produce our red blood cells? Where do we produce all of our blood cells? In the bone marrow, right? In the center of our bones. So production of all of our blood cells happens in bone marrow. And the things that stimulate this production of red blood cells are erythropoietin. Erythropoietin. I'm probably spelling it wrong. P-O-E-T-I-N, I think. Not sure. Erythropoietin. No, I was right. So erythropoietin is a hormone that stimulates this red blood cell production. And then remember, we talked about colony stimulating factors, like CSFs. There are all different types of colony stimulating factors that stimulate blood cell production. There's one called multi-CSF, multi-colony stimulating factor, that also stimulates red blood cell production, because that stimulates the production of everything except for lymphocytes. So that stimulates production. Stimulates all blood cells except lymphocytes, because remember, lymphocytes are weird. And then the last thing that you guys should remember about erythropoiesis or red blood cell production is you guys need to know the stem cells that the red blood cells originate from. Remember when we talked about the production of blood cells, all of the cells start as this hemocytoblast. And then remember that divides into either myeloid stem cells or lymphoid stem cells. So the myeloid stem cells give us the red blood cells, right? So like you could write it, if you wanted to write hemocytoblasts give us myeloid stem cells and lymphoid stem cells. Lymphoid stem cells produce only lymphocytes. Myeloid stem cells produce all the other types of blood cells. So myeloid stem cells end up giving us red blood cells, white blood cells, and yes, platelets. Well, okay. White blood cells besides lymphocytes. So we could say granulocytes.
Never let monkeys eat me.
We'll get there. Yep, we're going to get there. Granulocytes, which are neutrophils, eosinophils, and basophils, and then monocytes. Right, so again, you could say everything but lymphocytes. It'd be an easier way to summarize everything here. So if I ask you, platelets originate as what stem cell? Myeloid stem cell. Right? Red blood cells originate as what stem cell? Myeloid stem cell. Right? Lymphocytes originate as what stem cell? Lymphoid stem cells. Or if I ask you, which of the following stimulates red blood cell production? Erythropoietin or multi-CSF. All right, so the next thing is there's a few different kind of questions that talk about blood pH because we hit this in multiple different chapters. In the blood chapter, which we're talking about now, we just kind of talked about what the normal pH is. We didn't really talk about carbon dioxide and the way it affects it or anything like that. We did that later in respiratory. But for right now, just when we talk about the blood in general and characteristics of the blood, remember that we said the pH of blood should be between 7.35 and 7.45. If the pH is less than 7.35, then it's too acidic, right? Remember, low pH is acidic, high pH is basic. So if it's lower than 7.35, the patient has acidosis. Now, does that mean that they have too many hydrogen ions or too few? What makes something acidic?
Oh, they would have too many.
Too many. Hydrogen is what makes, like an acid is hydrogen, literally. Like hydrochloric acid is hydrogen and chloride. So the more hydrogen ions, the more acidic. So if the pH is less than 7.35, they have acidosis, meaning they have too many hydrogen ions. If the pH is greater than 7.45, they have alkalosis, right? The pH is too basic or too alkaline. And that's the opposite problem. That means they have too few hydrogen ions. If the pH is in between these, they don't have anything. No, nothing wrong. Okay, so if the pH is 7.38, great. 7.42, great. Okay, sorry, I've never like gone through that information this way with like no rhyme or reason behind it. That's totally organized, so I'm trying to like kind of keep it a little bit organized as I go. Okay, so you did that, that's good, okay. So red blood cell production, we said, was erythropoiesis. The other ones just follow the naming, right? So like thrombopoiesis is making thrombocytes, right? Leukopoiesis, white blood cells. Lymphopoiesis, lymphocytes. And we already talked about, okay, we did myeloid stem cells and lymphoid stem cells. Let's talk about specific types of white blood cells. White cell production, white stem cells, types of white blood cells. Actually, before we do that, let's just do blood type real quick, because there is a question about blood type. So kind of keeping in line with talking about erythrocytes. Remember our erythrocytes, or our red blood cells, have little identifiers, little antigens that stick out on their surface, and that tells us what blood type they are, depending on what like antigens they have. Remember, they could have A antigen, they could have B antigen, and they could have RH antigen. Any combination of those, or none of them. So let's just look at the different like possible blood types. If the person has A positive blood, their red blood cells, so this is the red blood cell, is going to have that A antigen. That's where the A is coming from, and it's going to have the RH antigen. Remember, positive and negative just refer to whether or not RH is there. If it's positive, RH antigen is here. If it's negative, there's no RH there. So like a negative blood, the red blood cell would have A, and that's it. Right? A means it has the A antigen. Negative means there's no RH. It's negative for RH. AB positive, the red blood cells would have A, right, B, and RH. So then you get the point, right? If it's B positive, it has B and RH. The only other kind of weird one there, remember, is O. So O, negative blood. The red blood cell has no antigens on it, no identifiers at all. O means it does not have A or B. That's what O means. And then negative, remember, means it does not have Rh. If it was O positive, the red blood cell would only have Rh antigen on it. So the antigens are just the identifiers that stick off of the red blood cell. Remember that our body has antibodies that fight anything that's not us, right? So this isn't just for blood type. Like in general, we have antibodies that travel, they're part of our immune system. They travel through our body and they'll bind to and fight anything that's not our cells. So when we look at the red blood cells, if A antigen is us, that's normal, and Rh antigen is us, that's normal, that means the body is going to have antibodies that fight B.
Which will initially cause clumping.
If you put a blood cell that has B in there, yeah. But just normally in this person's body, nothing would happen because there's no B antigen. Remember, the possible antigens are A, B, and Rh, right? Those are the possible antigens that can be there. So the body is going to fight anything that's not its normal self. The one weird thing there, remember, is that with Rh, when you're born, your body doesn't have antibodies that fight Rh. Your body just doesn't know that that even exists. But if we were to expose you to it, then your body would make those antibodies. Like this one here, A negative would have antibodies against B. It does not have antibodies against Rh yet, but if it were to get exposed to, like say we gave it a transfusion with A positive blood, then the body would see this Rh and it would make antibodies that fight it, right? So it would end up having the Rh antibodies like this. I do not have a question on there about blood transfusions, I don't think, but I do have a question about like blood type. So either I'll say the person has these antigens and these antibodies, what blood type do they have? Or I'll give you the blood type and ask you what will they have in their blood. So like if I say a person has AB positive blood, what will they have in their blood? You'll say their red blood cells have A, B, and Rh antigens. They have no antibodies, right? Or if they have A positive blood, they'll have A and Rh antigens and anti-B antibodies, okay? Okay, so the last thing then is just talking about, actually two things. One, we need to talk about the different types of white blood cells and what they do. We'll talk a little bit more specifically about the we'll talk about those in lymphatic. And then we just need to talk a little bit about blood clotting, not a lot of detail, just a little bit. So first off, when we look at the white blood cells or lymphocytes, remember we have 5 different types, right? When we put them in order of their differential, you guys said it was never let monkeys eat bananas. So neutrophils, lymphocytes, I need to hurry up, monocytes, eosinophils, basophils. You guys should just be able to give me a general function of each of these, kind of like what we did in the lab, how I just listed out like a couple specific functions for each of them. So neutrophils
are good phagocytes, and they do increase inflammation as well. Lymphocytes are responsible for our specific or acquired immunity, and they include T cells, B cells, and NK cells. We'll talk a little bit more about those in the lymphatic system. Monocytes become macrophages, and they are really powerful phagocytes,
Which means like cell eaters, they engulf things.
Eosinophils have a weird reaction that's different than the rest.
Most immune system things cause inflammation, right? Like almost every response in the immune system increases inflammation. Eosinophils are different.
Eosinophils actually decrease inflammation.
They can phagocytize things, but they don't have to.
They can also kill things from the outside. Remember, we see increased eosinophils in allergic reactions. That's important clinically. In allergic reactions and parasitic infections.
They happen to be good at killing parasites.
Finally, basophils. Basophils, they release histamine, which increases inflammation, causes a lot of inflammation. And they release heparin, which prevents blood clots.
Because you're bringing a bunch of blood to the area, you want it to flow nicely. All right, so the last thing, guys, for chapter 1 is you guys should just kind of be able to tell me a little bit about hemostasis. Hemostasis, remember, is like, or specifically about the stages of it. But hemostasis is like when you stop bleeding, right? So if we break a vessel, and blood is leaking out of that vessel, we need to stop that, right? We need to stop that bleed or that loss of blood. And remember, we have 3 different phases or processes that allow us to do that.
We have a vascular phase, platelet phase, and then the coagulation phase. In the vascular phase, there's hormones called endothelins, and they cause constriction.
Because if the vessel's big and it's losing blood, well, if you cause it to squeeze shut, you're going to lose less blood, right? So endothelins cause constriction of the vessel. There's more that happens, you guys, but I just, again, the final exam is a lot of highlights. It's a lot of big concepts. So that's what we're going to do here.
During the platelet phase, a platelet plug is formed.
Because the platelets get really sticky and stick to each other. And remember, that can kind of plug up a small hole in the vessel. And then during the coagulation phase, remember there's a whole lot of reactions that happen, right? That's like the cascade reactions where like there's lots and lots of chemical reactions. Ultimately, the chemical reactions lead to the production of a fibrin clot. Remember, fibrin is an insoluble protein. In our bloodstream all the time, we have something called fibrinogen, but that's soluble. It dissolves in the blood, so nothing happens. It's flowing through the bloodstream like nothing. But these reactions, like the very end of them, right? Like one leads to the next, leads to the next, leads to the next. And then the last thing we do is convert fibrinogen into fibrin. Fibrin does not dissolve in our blood. So instead of spreading out and dissolving nicely, it stays in these like threads. And those threads form like a mesh that traps red blood cells and platelets, and that's why the blood gets thick and sticky because of all of that fibrin. Okay, so that's what the coagulation thing is. Okay, that is it for blood. Not bad. Now, let's move on to the heart. Okay, so let's do this. You guys should just first off kind of remind yourself about the general like shape and structure of the heart, because you guys do need to know like how the blood flows through the heart, right? Like when the blood returns from the body, what chamber does it go into, right? What chamber pumps it to the lungs, that kind of thing. So first off, just let's think about the heart. The heart has 4 chambers. Remember, up top are the atria, so like right atrium and left atrium. And then on the bottom, right ventricle and left ventricle. So you guys should know what goes in or out of each chamber, right? So deoxygenated blood, deoxy blood from the body goes into the right atrium. Deoxygenated blood from the body goes into the right atrium. Then remember, it just goes to the right ventricle. And the job of the right ventricle, so right ventricle pumps deoxygenated blood to the lungs. So the job of the right ventricle is to pump deoxygenated blood to the lungs. Because remember, the whole point is to go to the lungs to get oxygen. Then the left atrium, the job of the left atrium is to receive oxygenated blood from the lungs. So oxygenated blood
from the lungs goes into the left atrium. Then remember, it goes down to the left ventricle. And the job of the left ventricle is to pump oxygenated blood to the body. Okay, so you should know the job of each chamber. There will be one question where I say, which chamber pumps deoxygenated blood to the lungs? Right ventricle. Which chamber pumps oxygenated blood to the body? Left ventricle. Okay, so the ventricles pump, the atria receive. The blood on the right side is deoxygenated, the blood on the left side is oxygenated. You guys should also remember the function of the valves that are in the heart. Right? Remember, there are 4 valves that are present in the heart. 2 of them are atrioventricular valves. So the 2 atrioventricular valves are the right AV valve, which remember is called the tricuspid, and then the left AV valve, which is the bicuspid. So those are the valves that are between an atrium and a ventricle. Okay, so if you were looking at the heart, remember there's a hole on each side between the atrium and ventricle because the blood needs to flow down from the atrium to the ventricle below. But when these ventricles squeeze and contract to pump blood out through these big vessels, we need to make sure that the blood doesn't go backwards, right? So we need to be able to close up those holes right there between the ventricles. That's what these AV valves do. They allow blood to go down from the atrium to the ventricle, but when the ventricle pumps blood out, they shut to prevent the blood from going backwards up into the atrium. So on the right side, the tricuspid valve prevents the backflow of blood from the right ventricle into the right atrium. The left AV valve, or the bicuspid valve, we also call that the mitral valve, does the same thing but on the left side. So it prevents the backflow of blood from the left ventricle into the left atrium. We also, remember, have 2 semilunar valves. The semilunar valves are at the base of these big vessels that lead out of the ventricles. Remember, when the ventricles contract, they're going to push blood out through these vessels, either to the lungs or out to the body. So at the bottom of each of these vessels, there's a valve. At the bottom of the pulmonary trunk, we have the pulmonary semilunar valve, also called pulmonic. And at the bottom of the aorta, we have the aortic semilunar valve. When the ventricles contract, the valves open and they allow the blood to go up and out of the ventricle. But then when the ventricle relaxes, there's nothing pushing forward anymore, and the blood tries to drop down backwards. We never want the blood to go backwards. So as the blood tries to drop down backwards, it closes, these valves shut, and it prevents the blood from going backwards into the ventricle. So the pulmonary semilunar valve prevents the backflow of blood from the pulmonary trunk into the right ventricle. The aortic semilunar valve prevents the backflow of blood from the aorta into the left ventricle. Okay, so there will be a question that asks you for a function of one of those valves. Speaking of the valves, remember that there are two heart sounds. Like when we auscultate or when we listen to the heart with a stethoscope, you hear two sounds, right? In like one cycle, you'll hear ba-ba, right, or lumped up. Those sounds occur because of the closing of these valves, right? So like when the AV valves snap shut, you hear a sound. When the semilunar valves snap shut, you hear a sound. So those sounds we call S1 or sound 1, and then S2 or sound 2. Sound 1 or S1 is when the AV or atrioventricular valves close. And remember, that occurs during ventricular systole, which brings up another question. What does systole mean? Contraction or good? Yep, systole is contraction. That's another question, guys. There's one question that asks you either what is systole or what is diastole. Okay? So systole means contraction. So the AV valves snap shut during ventricular systole. That's the first sound. S2, or the second sound that you hear, is when the semilunar valves close during ventricular diastole, which has told me diastole means relaxation or relax. So those are the sounds you're supposed to hear when you listen to the heart. Sometimes you might hear something you're not supposed to hear, and that's called a heart murmur. Okay, so a heart murmur is like a gurgling sound that you may hear if the valves don't close correctly. So if there's something wrong with one of those valves and they don't shut all the way, blood can leak up backwards through them. So you can hear that. You can hear the blood kind of gurgling up in the wrong direction. That's a heart murmur. Okay, so let's talk a little bit about the way that the heart gets stimulated, like the conduction system of the heart. remember that the heart is very special. The heart is muscle, but it's cardiac muscle. And cardiac muscle is very different from other types of muscle. Other types of muscle have to be stimulated by a nerve in order for them to contract, right? They don't contract unless a nerve tells them to. But cardiac muscle is different. Cardiac muscle can actually stimulate itself, right? It has the ability to tell itself to contract. It also, once one cell is stimulated, it has the ability to pass that stimulus from cell to cell to cell. So first, let's kind of mention why that is. This is what a cardiac muscle cell looks like. They're branched cells. And remember, here where two cardiac muscle cells are next to each other, they have these special little features. They're called intercalated discs, but what we're worried about is the gap junction. So cardiac muscle cells are linked together with gap junctions. Those gap junctions allow ions to flow directly from one cell to the next. And remember, in our cells, like electricity, when we stimulate a cell, that electricity that we stimulate, it's just ions moving. That's all electricity is ions flowing. So what stimulates these muscle cells to contract is an influx of sodium ions, right? So lots and lots of sodium flows into this cell, and that stimulates an action potential, tells it to contract. Because this cell has this gap junction that flows into the next cell, what happens is this sodium crosses through to this cell, and then that tells this cell to contract. And over here on this side, there's another gap junction that leads to the next cell. The sodium will cross through that cell, tell it to contract. So when we look at the heart, once we stimulate part of the heart to contract, that stimulus will spread from cell to cell to cell to cell until you get to something that stops it, right? Like if you have a whole band of like connective tissue or something, that'll stop it. But that's why like once we tell the atria to contract at the top, the stimulus passes all the way through the cells and all the atria contract. Same thing with the ventricles. Once we tell them to contract down there at the apex, that stimulus goes from cell to cell to cell, and all of those cells contract. So they all contract together because the cells are linked. Okay? They can pass the stimulus from one cell to the next because of the gap junctions. So let's talk about how it is that that first stimulus in the heart happens. Remember, I said that the heart does not need a neuron to tell it. The heart does not need a neuron to tell it to contract. It has its own electrical system. It spontaneously starts every single stimulus. We have neurons that can alter it, but its basic pace the heart sets for itself. So when we look at the conduction system, important parts of it that you guys should know are the SA node, the AV node, and we'll see the AV bundle, bundle branches, and Purkinje fibers. Okay, so AV node, AV bundle, bundle branches, and then finally at the bottom down here, all of these little fibers are Purkinje fibers. So you guys should know what each of these things does. The SA node, this is the thing that spontaneously depolarizes, like it spontaneously starts that electricity. And once the SA node gets stimulated, it passes it down to the cells, and it'll go down and down and down and down and down the atria to contract. Then that stimulus gets here to the AV node. Okay? It has to get passed through this AV node. It's kind of slow, it delays there for a second. Then that stimulus will go down the AV bundle. The bundle branches, which this is going down that septum, right, the wall between the ventricles. And then it goes to the Purkinje fibers. And the Purkinje fibers are actually going to give the stimulus to the muscle cells of the ventricle. So that's kind of the gist, right? We start at the SA node, we go through these little pathways down to the AV node. Then we go down through this septum between the ventricles, and then at the bottom, the Purkinje fibers give the stimulus to the ventricles to contract. So important things. The SA node is what we call the pacemaker of the heart. Okay? It starts every heartbeat, right? Or like every cardiac cycle. The stimulus starts in the SA node. So every time that SA node depolarizes, right, or every time the SA node fires, everything else is going to follow, right? And that's one heartbeat. Then the SA node fires again. Everything else follows. That's another heartbeat. So if the SA node is depolarizing at 70 times a minute, your heart's going to beat 70 times a minute. Okay? It sets the pace, and everything else follows. So that's the pacemaker. Also, the AV node, remember we said the AV node is kind of slow at, passing this signal. So the delay in the AV node gives time for the atria to contract before passing it down and stimulating the ventricles. Right, so the SA node is the pacemaker. It sets the pace that everything else follows. There's a little delay in the AV node. That's important because it gives the atria time to contract before we stimulate the ventricles. And then finally, the other little detail, the Purkinje fibers are the things that actually pass the stimulus to the ventricle, right, to the muscle in the ventricle. So the ventricle gets stimulated from the bottom up towards the top, right? So we start the contraction here at the bottom. And then remember, once we stimulate the cells at the bottom, that stimulus will pass from cell to cell to cell to cell, just like we mentioned, right? What's the stimulus going through? What are the ions traveling through? Gap junctions. Good. Okay, so however fast the pacemaker is going, that's how fast our heart is going to beat. If the heart rate is too fast, right? So if we have an increased heart rate, that's called tachycardia. So above normal heart rate is tachycardia. If the heart rate is too low, right, a below normal heart rate, that's called bradycardia. So tachycardia, bradycardia. Remember that we can look at or monitor these electrical events that are happening in the heart with a EKG, right, or like an electrocardiogram. When we look at the electrocardiogram, there were a few key parts that you guys needed to know. A normal heartbeat, like the normal electricity traveling through the heart, we should have a P wave, a QRS complex, and then a T wave. That's a little big. So a P wave, that P wave is the electricity that's telling the atria to contract. So the P wave is when we stimulate the atria. This is this kind of like weird looking signal, right, that goes down and then up and then down and then up. This is the QRS complex. That's when we are stimulating the ventricles. And then this last little hump here is the T wave. And that is showing us ventricular repolarization. So I hear it's like stimulate, you guys. Depolarization is a more technical way for me to say that. So like when we depolarize the atria. Here, when we depolarize the QRS complex is when we depolarize the ventricles. And then the T wave is when we repolarize the ventricles. Technically, like there is an electrical change that happens when the atria repolarize, but that's happening right here while the ventricles are depolarizing. So that electrical signal gets kind of absorbed into this QRS complex, right? So P wave, atria are depolarized. QRS complex, ventricles are depolarized. T wave, ventricles are repolarized. Again, you can also look at like heart rate in this by seeing how fast this is happening, and we've got tachycardia and bradycardia. If it's too fast or too slow. We said that the heart sets its own pace, but we do have neurons that come from the brain that can adjust that pace. So remember, like the autonomic nervous, if you think back to AMP1, the autonomic nervous system controls our heart rate. We have a sympathetic nervous system and a parasympathetic nervous system that can affect our heart rate. So the heart sets its own basic pace, right? The SA node sets its own basic pace, but if you get up and go running, you're going to need to increase that pace, right? And then when you sit down and relax, you're going to need to decrease that pace. So the neurons from the cardiac center in the brain stem, the cardiac center in the brain has neurons that go down to the SA node and can either speed it up or slow it down. So there are sympathetic neurons. Remember, the sympathetic nervous system is that fight or flight. So sympathetic neurons release epinephrine. They also release norepinephrine. But the sympathetic neurons release epi or norepi to increase the heart rate. And parasympathetic neurons release acetylcholine to decrease the heart rate. The last thing for the heart is talking about the different volumes of blood. So we talked about the end systolic volume. We talked about the end diastolic volume, and we talked about the stroke volume. And cardiac output. So end diastolic volume. You guys said diastole is relaxation, right? So end diastolic volume is the volume in the ventricle at the end of its relaxation. So that's when it's full, right? So end diastolic volume is volume at the end of diastole, or the maximum volume when the ventricle is full, right? The maximum volume in that cycle. It's done relaxing, all filled up, it's about to contract. So that's the most it's going to get in that cycle. Then it contracts, right? Systole is contraction. So the ventricle contracts, then it pumps some blood out, and then the ESV is the end systolic volume, right? That's the minimum volume that's left over after the ventricle contracts. The stroke volume is the volume of blood that's pumped out from the ventricle. So that would be the difference between these two, right? The end diastolic volume, so EDV minus the end systolic volume is going to give us our stroke volume. So if we put 100 milliliters into that ventricle, right? If the EDV was 100 milliliters, we filled it up, and then the ventricle contracts, and after it pumps out that blood, say it's left over with 30 milliliters. That would mean that the stroke volume was 70 mLs. It was able to pump out 70 milliliters during that contraction. Cardiac output is the amount of blood pumped by the left ventricle in 1 minute. Cardiac output, right? Like the output from the heart. Cardiac output equals heart rate times stroke volume. Makes sense, right? Stroke volume is how much is it pumping out. Each time it contracts, how much goes out. Heart rate is how many times is it beating. I think that is everything for the heart chapter. All right, so we did the blood, we did the heart. After that, we went through blood vessels, right? So moving on to the next chapter.
All right. So, talking about blood vessels. First off, just make sure you guys are fine with the type, like what each type of vessel does, right? Arteries lead away from the heart. Then we get to capillaries. Capillaries lead into the veins. Veins bring blood back to the heart. Capillaries are the only place where exchange happens. That's the only place where things can enter and leave the bloodstream. Couple other just basic definitions. Remember the inner layer, like there are 3 layers that line our blood vessels, right? The tunica intima is the inner one, media is the middle, externa is the outer. The inner layer, the tunica intima, is just a layer of endothelial cells. And then the media, the middle one, is muscle, right? That's where the muscle is that lines our vessels. Muscle is important because it allows us to constrict and dilate, right? So that's kind of basic concepts before I start writing down specific things. Okay, so first off, we said that capillaries are the only place where exchange happens, right? That's the only place where things can enter and leave the bloodstream. We talked about 3 types of capillaries. You should be able to put those in order. Actually, we take 4 types, but 3 major types. You should be able to put them in order from like which ones are the least porous, which ones are the most porous. Because remember, they have different like permeability. They let different things across. So the normal capillaries that we have through most of our body, most of our muscles and our skin, and most of our organs, those are continuous capillaries. Okay, so those are just like our normal capillaries. Then we have fenestrated capillaries. Okay, remember, those have like little pores in the endothelial lining, so they're more porous. We have those in places like our intestines, for example, our kidneys, right, the glomerulus. Then even more porous than that, we have sinusoids. Sinusoids have actual gaps between endothelial cells, so they're the most porous out of all of our capillaries. We have those in places like the liver, the bone marrow, the spleen. Okay, so least porous to most porous. We do have some special continuous capillaries, remember, that have tight junctions between endothelial cells. Those are very restrictive. The permeability in there is very, very little. For example, in the brain, right, that's what gives us the blood-brain barrier. Also in the thymus, right, that's what protects the T cells while they're maturing. And the testes as well. Those are the 3 areas. Okay, so types of vessels. When we talk about capillaries, we said that capillaries are the place where things can enter and leave the blood. The reason for that is they have really, really thin walls. They're only the tunica intima. So all they have is this one single layer of endothelial cells. So super, super thin walls. When we talk about things entering and leaving the blood, we call that capillary exchange, right? Things are going from the blood or between the blood and the interstitial fluid. There are a couple different pressures that are pushing things in each direction. The primary pressure that pushes out of the blood is capillary hydrostatic pressure. Right, so capillary hydrostatic pressure pushes out of the blood, from the blood to the interstitial fluid. Right, we call that filtration. The primary pressure that pulls back into the bloodstream, right, is blood colloid osmotic pressure. So blood osmotic pressure.
And we call that, right, the pulling back into the bloodstream is called reabsorption. So as we flow through a capillary bed, we filter out, we reabsorb back in, right? And that kind of like flushes things and mixes things around. Remember that blood colloid osmotic pressure, right? This reabsorption back into the bloodstream happens mainly because of plasma proteins that are in the blood. And then this capillary hydrostatic pressure that's pushing out is just mainly associated with blood pressure. Speaking of blood pressure, we'll talk about that now. Right, so there's one question talking about those pressures. Which pressure is doing what filtration is, what reabsorption is. Actually, before we get to pressures, let's talk about edema. So remember when we look at this, like filter, we push out of the blood and then we pull back in. We push more fluid out than we pull back in, right? Remember there's a little bit of extra fluid. I think it's like 3.7 liters a day. There's a little bit of extra fluid that's left out here in the interstitial fluid. Now, that's okay, we take care of it, right? Remember that fluid ends up like entering into the lymphatic vessels, and we clean it and then put it back in the blood. But sometimes that gets out of whack, right? Sometimes for numerous different reasons, we end up with too much interstitial fluid accumulating, right? And we call that edema. Actually, let me erase, make room. We call that edema. So you should know the definition of edema and then some things that can cause it. So edema is an accumulation or a buildup of interstitial fluid, and that causes swelling. This can happen for lots of different reasons. Edema can happen just because there's tissue damage. Right? We've all experienced that before. You'll get a bump or a bruise or some sort of an injury. That causes edema. It can happen because of starvation. When someone is starving, they don't have amino acids to make plasma proteins. Plasma proteins, remember we said, are what pull fluid back into the blood. So if you don't have those, you can't pull fluid back in. So fluid accumulates. That's what you see, like when you see like starving children. We see it a lot in like third world countries where the belly is really like swollen. It's called ascites when the belly swells. But the belly will be really swollen even though they're starving. And that seems like a weird paradox, right? You don't have any food, why is your belly so big? It's just edema, it's just pure swelling, it's not fat. So tissue damage, starvation, anything that increases circulatory pressure. So increased blood pressure, like this can happen, for example, with clots. If there's a clot, the blood can't leave, so there's like a back pressure that builds. So high blood pressure, blood clots, etc. And then heart failure. For the same reason, there's a back pressure of blood. When heart failure occurs, the heart can't keep up. So there's all this blood trying to come back to the heart, but it can't keep it moving. So the blood pushes back, and we end up with a bunch of blood stuck back in those capillaries. So we've got a lot of pressure pushing out. And then the last thing is liver failure. Liver failure is also associated with edema in the stomach usually, but the liver makes plasma proteins. That's why. So again, no plasma proteins. So you should know the definition of edema, and you should know different things that can cause edema. In case we don't get to it later, you guys should also know the specific lymphedema. So lymphedema is when edema or swelling occurs in an area. It's usually in a limb. But the reason it occurs is because the lymph can't flow. There's a blockage of lymphatic drainage. Remember, we said it's okay that we end up with extra interstitial fluid because it drains through the lymphatic system. Well, if you block that drainage, then it doesn't drain anymore. You can have really severe edema. We said that this was, so edema because of blocked lymphatic drainage. We said that this happens commonly when we remove lymph nodes. So like due to cancer, for example. So if somebody has lymphoma, right, cancer in a lymph node, we remove them. So I think there's a question where I give you an example of removing lymph nodes either in the underarm or in the groin, and then, you know, where would this patient experience edema? So if you remove the lymph nodes in the underarm, the axilla, then you can't drain from the arm. They would have lymphedema in that arm. If you remove them from the groin, you can't drain from the leg. So they would have lymphedema in that leg. So, because I am slower than I thought, and I don't think I'm going to get through all of these chapters. At least I got through a few big ones. Okay, so we mentioned capillaries. We talked about capillary exchange. Then let's talk about pressure. Did that one. So pressure, when we say blood pressure, we're talking about arterial pressure, right? Pressure in the arteries, like pressure that's pushing out from our arteries. Normally, when we look at blood pressure, we have two numbers, right? Like we say 120 over 80 is like a normal blood pressure. That's two numbers, right? So technically, when we talk about arterial blood pressure, we're usually referring to two different pressures. This high number right here is the systolic blood pressure, right? That's the pressure in the vessels when the heart is contracting. The lower number is the diastolic blood pressure. That's the pressure when the heart is relaxed. So that pressure is in the vessels regardless of what the ventricle is doing. Then the ventricle contracts, and that strength of the ventricle pushes out more blood. And so like in this case, the ventricle is generating 40 millimeters of mercury. The 80 is there anyhow. Speaking of, we use a term pulse pressure. The pulse pressure is the difference between the two, right? So in this case, the pulse pressure would be 40 millimeters of mercury. You guys should know what we call it when pressure is too high and when it's too low. So hypertension is high blood pressure, right? Hyper, above normal. Hypotension is low blood pressure. There are a lot of different things that affect the pressure in a vessel. So all right, a lot of different things affect blood pressure. Blood volume, right, is one of them. So if the more volume there is, the more pressure, right? And the less volume there is, the less pressure. One of the biggest things that we do to impact blood pressure is change the size of the vessel, right? Remember we said there's muscle lining the vessels, so the vessel can constrict and it can dilate. That has a huge impact on pressure. So vasoconstriction when the vessel squeezes, right? The vessel gets smaller, that increases pressure. And then the opposite is also true. Vasodilation decreases pressure. Blood pressure. Sorry, again, I'm like going through the questions, so it's not exactly in the order I would normally do this, but so we did talk about some different ways that we control blood pressure. We already talked about the cardiac center in the brain, right? That could increase heart rate, decrease heart rate. We talked about that last in the second chapter. But remember, increasing heart rate and decreasing heart rate, that can impact how much blood is present. So that can increase pressure, right, or decrease pressure. Also in the brain, we have the vasomotor center. The vasomotor center has the neurons that affect vasodilation and vasoconstriction, right? So input or output from the vasomotor center can also cause increases in pressure and decreases in pressure. And then we also have some hormones that can affect blood vessels and blood pressure. Remember, angiotensin II is a big one. Angiotensin II has a lot of effects, which you guys should know from the last exam. It causes increases in blood volume. It causes vasoconstriction. It causes the release of ADH, which causes more blood volume, aldosterone, more blood volume. But overall, angiotensin increases blood pressure and blood volume. So kind of along with that, ADH and aldosterone are involved in increasing blood pressure. The one hormone that decreases blood pressure, or the two hormones, I guess, are the natriuretic peptides. And the natriuretic peptides, ANP and BNP, they actually cause us to get rid of fluid. So they decrease the volume and decrease pressure. Okay, I will have one question that talks about hormones, not like in a ton of detail, but just asking, which one would increase pressure or which one would decrease pressure. When we talk about blood pressure, remember the reason we have to have enough pressure is to keep the blood flowing forward through the system, right? Pressure is what is pushing the blood forward. So we have to have enough pressure to keep it flowing. Remember, if we say pressure is pushing blood forward, resistance is what's holding it back. Right? So pressure is pushing forward, resistance is holding back. And there are a few different things that affect resistance. For example, like blood viscosity, right? Like how thick the blood is. The thicker it is, the more resistance, the harder it is to flow. Also, we said the big one there was the size of the vessel, diameter. right? So vessel diameter has the biggest effect on resistance. So the more constricted it is, the more resistance there is. Another thing is atherosclerosis. Atherosclerosis happens when somebody has really high cholesterol. Atherosclerosis is a disease with plaque buildup on the walls of blood vessels. Okay, so if you have a blood vessel, right, and like the blood is flowing through that vessel, and I have this plaque that's all built up on the walls like this, now all of a sudden, right, all of this is plaque, so it's much harder for the blood to flow. First off, there's less space, right, the diameter is smaller, but also this creates turbulence in the blood flow. The blood can't flow nice and smooth anymore, right? As the blood's trying to flow, it hits the walls and it bounces up in these other directions. So atherosclerosis increases the amount of resistance and makes it harder for the blood to flow. Another disease state having to do with blood vessels is an aneurysm. All right, aneurysm, I think so. An aneurysm is when there's a weak spot in the vessel wall.
And it pretty much just goes through that vessel. So then you're initially not getting blood anywhere else.
If it bursts.
Right.
Yes. So remember that especially our arteries, the walls are elastic. So when there's a whole lot of pressure, they just stretch. And then when there's not a lot of pressure, they snap shut. So just like, elastic clothing, I can put stress on these and it's fine, right? They're not ripping, they're elastic, no worries. If these were jeans and I yanked on them, I would break a button, right? They would break in some way because they don't stretch. So in our vessels, if, I have a vessel and this area of the elastic here is really weak, then the vessel will start to bulge out in that area, right? I start to get like a little balloon because it can't withstand the pressure any longer. And as that part of the vessel balloons out, it gets thinner and thinner, weaker and weaker, weaker and weaker. That's an aneurysm. Aneurysms can burst. So say this person has an aneurysm and it's real thin and real weak, and all of a sudden they go on a roller coaster. Or they decide, I'm going to go for a really fast run, and their pressure goes up really high. They're going to blow that aneurysm. That's a ruptured aneurysm. So a ruptured aneurysm can result in a stroke. And you guys should know the two types of strokes. There is a question about one of the two types of strokes. So a stroke is just when we interrupt blood flow to the brain. We can have a hemorrhagic.
Yeah.
We can have a thrombotic stroke or a hemorrhagic stroke. A thrombus is a clot. So a thrombotic stroke is when a clot blocks blood flow to part of the brain. So in this case, right, I have my brain. This is my wonderful little brain here. And I have my blood vessels, right, going to my brain. And as the blood vessels branch, they get smaller and smaller and smaller. So say I have a blood clot here, and the blood clot's flowing through the blood, and it's going okay, but eventually it gets to this vessel here, and the vessel's too small. Can't go any further. So the blood clot gets stuck here, and it blocks that blood vessel. Now all of this part of the brain over here is not getting blood anymore. So that's a stroke, thrombotic stroke, because it's caused by this thrombus or clot. So this part of the brain gets damaged, and we need to either remove it or bust it up or whatever. A hemorrhage is a bleed. So a hemorrhagic stroke is a stroke that occurs because of a bleed. That's what happens when you have a ruptured aneurysm. So here, say, this is a vessel going to the brain, and we have this aneurysm. All of a sudden, our guy who, got up and started running really fast, pressure increased, he blew out, he ruptured this aneurysm. Now the blood that was flowing through this vessel is going to start leaking out through that whole vessel. So the blood's not going to make it over here to this part of the brain anymore because it's leaking out instead. So it's still a stroke because we've interrupted blood flow. It's just caused by a hemorrhage. Right? So you guys should know thrombotic stroke versus hemorrhagic stroke.
Are hemorrhagic strokes worse typically?
It depends. Yes, here's the thing with hemorrhagic strokes. There's two problems with the hemorrhagic stroke. One is you're not getting blood over here. The other problem is you have a buildup of blood over here. So you're also pushing the brain in that area. So that's the reason that a hemorrhagic stroke is really problematic. It's also harder to treat because you've got to go in to treat it. Whereas sometimes with a thrombotic stroke, we can give a thrombolytic, we can give a medication to break it up. So hemorrhagic strokes are a bit harder to manage than thrombotic.
I was going to say an aneurysm that bursts in the heart would be like the worst because you have seconds to
So normally there's not an aneurysm in the vessels going to the heart, but the vessels near the heart, which I think is what you mean,
yes,
like the aorta.
Yes, the
yes,
aorta.
yeah, you die if you have a ruptured aortic aneurysm. Seriously, unless you're in the hospital, they have you on the table and you're opened up already, and they can close it right then.
Yeah.
It's like
Because that goes to everywhere.
Yeah, and there's such pressure. Remember, it's right by the heart, so there's a ton of pressure. So when it ruptures, so much blood is lost that it's really hard to make it past that. Okay. So when we talk about the types of vessels, I told you, we said arteries lead away from the heart, veins lead back to the heart. Just remember some of the major differences between those vessels. Arteries are really elastic and really muscular. Veins have thinner walls because there's less pressure in them. And also remember that veins have valves. Arteries don't, capillaries don't. Okay, veins are the only vessels that have one-way valves in them, and that's to help keep the blood moving forward. Because remember, once we get to the veins, there's not very much pressure. So those valves help to ensure that the blood doesn't drip down backwards into the legs. I think we might have done everything from okay, that's everything from vessels. I told students I have it's 10 minutes to 12. I was going to meet students 5 minutes ago, but let me see if in 10 minutes I can really quickly at least tell you some things to focus on for the lymphatic chapter. And that at least gets you halfway through the semester. Disease states, guys, make sure you guys look at the disease states that we looked at in lymphatic. So we looked at HIV. Remember, HIV is a destruction of the CD4 cells, or helper T cells. And remember, that makes you more prone to infection, right? Opportunistic infections. And then we talked about lupus, SLE, systemic lupus erythematosus, erythrocytosis, which is an autoimmune disease, yes, where your body attacks your own body cells. And it's associated with problems all over the body, a lot of pain, it's organ damage, there's that butterfly rash on the face is a characteristic thing that you see. Also, make sure that you guys know kind of the general function of each of the organs in the lymphatic system. So just kind of like surfacey function of each of them. So for example, like the lymph nodes filter the lymph and they activate the immune system if there's an infection in, one of the tissues, like the interstitial fluid. You should know, so those are the tonsils, right? Tonsils and Peyer's patches, like those are, tonsils are like little masses of immune, masses of connective tissue with lots of lymphocytes that monitor for infections, like if you're eating. Your spleen, remember, the wrong side, spleen. Your spleen is up over here in your left upper quadrant, which that is important because remember the spleen is damaged really easily. So like if you break a rib over here in the left upper quadrant, it's possible that that could puncture the spleen. So spleen, left upper quadrant, and the spleen filters blood, right? Remember, it checks the blood for infection. So if there's infection in the blood, the spleen would then activate the immune system. Also remember that the spleen is important in hemorrhage. So if we lose a lot of blood, the spleen is important for helping to manage that blood loss because we store a ton of platelets there. Okay. And then also as far as the spleen goes, if it's damaged, remember it's hard to repair, so we just remove it. Okay, that's a splenectomy. So spleen, lymph nodes, lymphatic vessels, and lymph. Remember we said that we drain extra interstitial fluid through those lymphatic vessels. That's kind of like the function there. Okay, then also lymphatic system-wise, know about the different types of immunity. So remember active immunity and passive immunity, and then naturally acquired and artificially acquired. Okay, so like know the difference between each of those. There's a question where I say, which of the following is naturally acquired passive immunity, or which of the following is artificially acquired active immunity. Okay, so there were like 4 total types in there. Make sure you know all of those. Know the difference between specific defenses and non-specific defenses. Right, so specific, remember, is your B cells and your T cells. They fight specific antigens. And remember that's acquired immunity. You're not born with that. Your B cells and T cells, like they have to be exposed to an antigen before you mount this whole big response to them. And then non-specific defenses, remember, are things like fever, interferon, NK cells, barriers like our skin and mucus, acid, all of that's non-specific. You've got it from birth, right? It's innate, and it works the same every time, no matter what the pathogen is. Speaking of, we talked about lymphedema. Speaking of the non-specific defenses, know, like, not all the details, you guys. So again, this is all very surfacey for the final exam, but know kind of the basic function of each of those non-specific defenses. So, like barriers, like your skin, they help to keep the pathogen out. Phagocytes just eat and digest the pathogen, like your macrophages, for example. Interferons are key in the fight against viruses. Okay, so interferons against viruses. So you see what I mean, right? Like just like kind of the key point for each of those non-specific things. And then as far as B cells and T cells go, B cells are antibody-mediated immunity, right? They lead to the production of antibodies, which help clear pathogens from the body. T cells are cell-mediated immunity, right? We have know the difference between helper T cells and cytotoxic T cells. Okay, so helper T cells, remember, are CD4 cells. Cytotoxic T cells are CD8 cells. And then again, just like kind of a key function of each. And know what that means. CD4 means that it has the CD4 T cell receptor. CD8 means it has the CD8 T cell receptor. When we talk about B cells, kind of just general, like when B cells lead to, how do I phrase this? Okay, so B cells leading to antibodies, remember that like the B cell, once it's activated, turns into a plasma cell, and then that produces the antibodies.
So like NK cells.
And then NK cells are also lymphocytes, but remember they're non-specific. Okay, and then I think that that's it for the lymphatic system. Yeah, that's it for the lymphatic system. And then for the endocrine system, guys, just as you go through the endocrine system, just very surfacey. This gland releases these hormones. This is the very basic gist of what it does. Okay, so like, oxytocin, contractions. So that's one that I could easily ask you medical-wise, right? Like labor stalls, what hormone do you give? Oxytocin. Pitocin. That's the medicine form of oxytocin. Prolactin. Prolactin is for breast milk, right? So if a patient isn't producing breast milk, what hormone might they not have? Prolactin. So just like basic functions, right? Melatonin, circadian cycles. Also, that, yes.
What if we just like refer to that chart?
That's
Would that be
great,
good
but
enough?
not detailed though.
Okay.
Like there's probably more detail in that chart than you need.
But just like basic.
Yes.
Okay.
Yep. Just that would be a great way to do it. Yeah. Just grab the chart,
Yeah.
grab the hormone chart, and hit the high points off of it. And then anything disease related with that, like we talked about hyperthyroidism. So know the symptoms of that, right? If you have a patient who presents with weight loss, insomnia, anxiety, sweating, what of the following might they have? Hyperthyroidism. Whereas the opposite, if they have unexplained weight gain, drowsy, sluggish, what might that be? Hypothyroidism. And then as far as insulin and glucagon go, those are big medical ones that are going to be important later. So maybe understand a little bit more about like what those ones do, a little bit more in depth as far as like when you have a lot of, like when you eat a meal and you have a lot of nutrients, insulin gets released from beta cells. And remember, all of the functions of insulin have to do with using and storing nutrients. Right? So you convert glucose into glycogen. You use your glucose. You don't want to make any new glucose because you have a ton of it. Glucagon is the opposite. Glucagon gets released when you don't have any sugar. You haven't eaten in a long time. So with glucagon, you need to make sugar. So gluconeogenesis occurs. Where you make new glucose. You break down glycogen into glucose. So that's like more of I need to liberate resources with that one. Okay, and glucagon comes from alpha cells. So like keep those a little bit more detail on. Yeah, and then I think that's it for the diabetes. Know what diabetes is and what it's associated with, symptoms of. I think that's the other disease that I covered was the thyroid issues and diabetes. And that's all I have time for because I have students making up a test like 15 minutes ago.
Thank you for your time.
You're welcome, guys. You're welcome.